Well, I really appreciate being here. As I shared with your dean, it is my first trip to Louisville, and it's been a very positive experience so far. I feel really fortunate to catch the weather, I think, in a favorable direction. My home is Salt Lake City, and so I left behind, teens and snow. And so everything that I've seen here has been most welcome, and the greetings have also been very warm also. David, I think, heard me talk a little bit about medical mistakes and the issue of disclosure of medical mistakes at a meeting of people interested in bioethics. And I think that probably was the basis for his asking me to talk in this area. As he mentioned, my own training and background includes infectious disease as well as medical ethics. And I'll talk to you today a little bit about mistakes that I've made in both areas and maybe contrast the experience. This is from the work of Marion Paget, who's a person who has interviewed quite a number of physicians, and if I recall correctly, David, many of them were family practice physicians, to understand how doctors thought about the problem of medical mistakes and medical error. And Dr. Paget concluded that they thought, and she agreed, that medical work is an inherently error-ridden activity. By its nature, it's inaccurate and practiced with considerable unpredictability and risk. And she said, especially those essential activities of diagnosis and therapy. And I read, what other activities are there? I mean, that's essentially the defining characteristics of medicine. And actually makes me wonder why we call it the practice of medicine, right? Because if practice makes perfect, we're always on that road, but we never quite get there. So I actually like the language of practice, which I think is very revealing. That is, we're working toward getting it right, but we rarely get all the way there. And there are some peculiar things about medical errors. I think all of us have experience with errors in our lives, but what might be unusual or different about medical errors? And I think the first thing that's really interesting is how difficult they are to discover. So for an example, an accountant who works with numbers all the time, if they work with computers now, they actually rarely get past the screen with an error because there's an error check mechanism. Even people who have difficulty spelling actually have those mistakes called to their attention. They're underlined and flagged in Word or WordPerfect. And so you have this awareness of mistakes as fast as you make them. Whereas in medicine, quite the opposite is true. And we'll be returning to that. That is, the errors that we make actually are very challenging in terms of our own recognition of them. I guess one thing that helps me think about how hard it is to make mistakes is that something like all men make mistakes, but married men hear about them sooner and more often. So I think in its own way, that's actually very helpful. That is, it sometimes takes someone else or the passage of time to make us more aware of the errors that we've made in medicine. Second peculiar point, bad outcomes are overdetermined. And I'll be coming back to this periodically. I think in general, we equate bad outcomes and mistakes, right? We get lost going to a friend's party, right? We're lost. That's the bad outcome. That's what tells us that we took a wrong turn. So bad outcomes are a signal, in general, that mistakes have been made. But think about medicine. People are very sick. They sometimes have multiple organs that are failing. The sickest patients are on the most drugs. The drugs interfere with each other. The more drugs that are prescribed, the more chance to make an error. Bad outcomes are really overdetermined. Sometimes we need to remember that even when we've done everything correctly, people still die or fail to recover from a serious illness. And so being overdetermined just adds to the cloudiness. That is, using that common association between bad outcomes and mistakes can be quite misleading in medicine, right? The bad outcomes can be due to so many different things that we lose track of the connection between error and bad outcomes. We don't expect mistakes, and we're not modeled to. That is, as trainees, we work with people who are very expert. Again, because mistakes are not always apparent, we're led to believe, despite Marianne Paget's comment, that medicine may not be an error-ridden activity, that people who are really good in medicine don't make mistakes. So we don't actually kind of start with the idea that mistakes are either inevitable or common. We instead think that they may be rare and avoidable. I think this one is particularly true of medical mistakes. So the connection here is that when I was a medical student, There were lots of people looking over my shoulder that would catch or identify mistakes that I was making, right? I had an intern, a resident, an attending, the consultants, and all of the fellows. The nurses and the nursing supervisors. I mean, the people above me could hardly be enumerated. I was so low, right? So lots of oversight and very little responsibility. But should I make a mistake, there was a pretty good chance that it would be caught. Now look at where I am. I'm the attending. And if I want to look over my shoulder, it looks pretty empty out there. That is, when I'm on the service, even my partners feel free to go to meetings or leave town. So my peers are gone, and the attending, my chief of medicine, in general, knows less about my subspecialty than I do. And then underneath me are a whole series of people who either know less than I do, or who might even be intimidated from sharing with me what they do know when they see me making mistakes. So there's the paradox. At the low end, where I'm prone to make mistakes, I have a lot of supervision. Well, I'm still prone to making mistakes. The fact that I'm an attending hasn't changed my propensity to making mistakes. It just changes how likely I am to know about them. So there's this inverse relationship between responsibility and oversight. And then finally, and of course the obvious, in medicine, our mistakes can literally have lethal consequences for others, and frankly, pretty bad consequences for ourselves. And so here's a metaphor for the way doctors deal with mistakes, right? Commonly said, doctors bury their mistakes. But what I want you to do is read the headstones. Can you read those? Okay, so in a way, that also fits with this idea that mistakes may even be unrevealed or undiscovered by us, right? These are bad outcomes. Everybody there, I hope, has had a fatal outcome, right? We don't bury people that are not dead. But the idea that it's their fault, somebody else's fault, or nobody's fault is often the way we come to grips with bad outcomes, which, as I've said before, are overdetermined, but some of them are the result of mistakes. So this is another way that we bury our mistakes, often unknown to us, right? There was a mistake here, but we either haven't acknowledged it as that because it's easier to blame than to acknowledge that, or maybe we just haven't recognized it. So why did I talk about, our title today is Unmasking Medical Mistakes. This was a cartoon that appeared in the New York Times a number of years ago, probably around the time the Institute of Medicine report appeared in 1999. And I think actually it's very descriptive. That is, I'll try to picture myself or one of my residents sitting in the chair, and in general, one of the responses within medicine is not to see the mistake as such, right? Or not to really want to talk about it as an error, and not certainly to discuss and offer guidance and maybe a receptive ear to the person who has experienced that kind of personal anguish in the chair. So my goal is, in a way, to take our fingers out of our ears and our hands from in front of our eyes, and hopefully take the hand from in front of the head of this individual who is struggling. One of the things you want to picture in this chair is this is actually after a significant event has taken place. The reason this person is uncomfortable in the chair is they're actually experiencing awareness of a mistake. So remember the first thing that I said, we can all be going happily about our business, not holding our hands to our head, but we could be making mistakes willy-nilly. That could be happening to me on any given day when I have lots of decisions to make about really sick and complicated patients. But here there's personal awareness, and it also points out another failing, that as a culture in medicine, we're really not very supportive to this individual after that event. And that actually includes a lot of important initiatives. We have very big initiatives now about patient safety. And I think they're actually wonderful and constructive, and hopefully they're reducing errors. What I would say is that I think we should acknowledge that even with maximum efforts at patient safety, we will continue to see mistakes. So what I'll be talking about today is mistakes once they've happened. There will be other people, and perhaps have been other people, to speak to you about the prevention of mistakes, but I'll be talking about mistakes that have occurred. And why would that be important? Well, I see Mark Rothstein here, and you know that for many people the importance of mistakes runs quickly to the idea of litigation. In fact, that's one of the consequences for physicians that they fear greatly. But really important to acknowledge that litigation is a tiny fraction of the response to medical mistakes. Serious medical errors with real consequences are at least 40 times more frequent than the litigation that occurs in response to them. So if we want to talk about a serious problem, the problem is right there. It's the problem of the mistake, quite independent of the litigation issue. I've already alluded to the 1999 report, and I'll show you some numbers in a little bit more detail, but it drew our attention to the frequency of medical errors, particularly medical errors that lead to death. And as a consequence, the accrediting organization has required hospitals, certainly asked hospitals, to report medical errors and mistakes. And in my environment and in yours, where we have students and trainees, I just make this point to acknowledge the reality. That, remember what I said about responsibility and oversight. We all have the idea that our students and residents are prone to make mistakes. They're learning. That's why we have oversight. So residents make lots of mistakes, but so do we and everybody else. And the point of calling your attention to it is that while the numbers of mistakes that residents make can be reduced by careful teaching and good oversight, they will continue to make some mistakes as attendings. They will make new mistakes. There are new medicines, new technologies, and certainly new patients that invite the possibility of an error. So the reason to call attention to the residents is this is our first, and certainly the medical students as well, opportunity to change that culture of how we deal with mistakes. So think about the first slide, think about the person in the chair, and make that person a student or a resident. And then think about what we could be doing at that point in their training to not only help reduce the likelihood of mistakes, but to deal with the consequences of mistakes. And I think that supports the last point, which is we don't do a lot of talking or teaching about mistakes. We actually almost would prefer to pretend that they don't happen. But that's really in itself detrimental, right? It creates an unfulfillable expectation that somebody who's finished their training could go out into a career ready to practice medicine and not make mistakes. The mistakes in medicine, and I'll use mistakes as shorthand here for medical mistakes, and I'm going to argue that they're both complex and difficult, and in two, and again, it's like diagnosis and treatment, that, you know, a few areas of medicine, diagnosis and treatment. Where else could it be complex and difficult but intellectually and emotionally? So intellectually, think about the problem of discernment and discovery. We've already said they're overdetermined, right? So it's not clear here. For example, bleeding is not so complex. You can usually see bleeding in the operating room. So intellectually, it's not hard to recognize, maybe a little hard to deal with, but there's not a lot of discussion, is he bleeding or not? But there's plenty of intellectual discussion about whether this was a bad outcome, whether it was a bad outcome due to a mistake, and if it was a mistake, is it a mistake of judgment, right? Or was it just, you know, bad choice, but an unpredictably bad choice? And then emotionally, once again, terribly complex, and the emotions here are really serious. The emotions that go with making mistakes for physicians are senses of failure, embarrassment, shame, and guilt. You didn't hear me mention anything that you would call a positive motivator, right? This is not about joy and happiness, contentment, or satisfaction. These are all very powerful negative emotions, and they're complex because they interact with each other. I mean, the feeling of, for example, failure in inadequacy can be incredibly damaging at the next instance of applying those skills. Right? If you've made a mistake and you think that that emotionally means you're worthless, not intellectually, but emotionally, right, and incapable, what does that say about your confidence in the next procedure that you do that might be like that? Think about the surgeon, for example, with a serious error, and then think about how you would feel if you made a bad error during driving, right? It may be hard to get back in the car the next time. So that's that emotional complexity. Important to everybody, but important in slightly different ways. Obviously, medical consequences of a medical error are experienced by a patient, but certainly in our system, by that I mean the American system, there are financial consequences to American patients who've had medical errors that are very different than, say, European patients, right? So here's somebody who's been fully insured, goes to the hospital to have an elective procedure, has an error that renders them disabled. Lost their job, right? Maybe disabled for that particular job assignment, but not technically disabled for health benefits. Loses their job, loses their insurance, needs a procedure that's a reparative procedure, but it's not uncovered. Or maybe has a lifetime of needing medical intervention, which will go uncovered in that situation. So just paying for the medical consequences in our system is quite a burden on patients, not to mention, of course, other financial things about maybe the inability to work. Emotionally can be very scarring. And again, the way that's handled, very important. Patients, take my example, enter the hospital for an elective procedure expecting a good result, has a terrible result, but for a while doesn't even understand this to be a mistake, but then comes to discover that it was. It's huge in terms of anger, disappointment in the medical system, and perhaps lack of trust in future healthcare providers. So emotional consequences pretty severe. For physicians, medical mistakes, certainly in terms of reputation, which is very important to us, right? Acknowledging a mistake among a group, acknowledging you're less than perfect, oh my goodness, right? So just on the level of reputation, but can be more serious, right? Several, maybe there are litigation actions, et cetera, properly based or not, that's shared and reported. So credentialing issues become an issue in terms of future employment. So kind of a barrier to wanting to be candid about mistakes. Financially, it's a little bit inverted from the patient, but still important. Physicians often will not pay out of pocket for a mistake that they've made, but there are financial consequences. If you've chosen a profession in medicine, remember Marianne Paget, which is error-prone, like delivering babies who may be less than perfect, the insurance premium that you pay ties back to the story about mistakes. If the carriers believe more mistakes are likely in your area, your premiums will be higher. So there is a financial issue, not even for your own mistake, right? Physicians bear the financial burden for the mistakes of their specialty or for the perceived mistakes of their specialty. And then, of course, if any of you know physicians who have had suits filed against them, or quite honestly, who have shared with you that they've made a lethal mistake, the emotional toll is enormous. I mean, there are people who have left their specialties. My story about a car accident and having trouble to go back into an automobile, someone who has misdiagnosed an issue in pregnancy that's left to a baby born dead. Nice example in the literature is David Hilfiker, who's written a book about this called Healing the Wounds. There are people who've left that discipline for fear that they would make that same mistake again. So the emotional toll, pretty serious. I hope this is self-evident, right? But I told you that I'd show you a little bit more detail about the Institute of Medicine. So it isn't so much to show you the number, which I think you've heard a lot about. The red bar was their estimate based on a meta-analysis of a number of other studies that the deaths attributable to medical errors range between 44 and 98,000. What the point I wanted to make was where that's positioned relative to other things. Because I think that's really very telling if you think about what people are worried about. So, for example, women have a high level of concern about breast cancer, right? But the number of deaths from breast cancer every year actually lower than the low end of the estimate for deaths due to medical errors. It's actually kind of an interesting problem. If you thought about then just going to the hospital because you feared one of these other things, actually you could reconstruct that, right? The chances are that medical error is more likely to be a serious problem for you than the disease that worries you the most. So I think just this hierarchy is a helpful thing to think about. And then buried within that are the medical errors due to different things, and some of this work has now been replicated. So if you look down at the bottom part of this slide, they estimate that drug-related or medication errors are about 10%, and if you go about halfway in between, 44 and 98, if you think about 70,000 and 10%, you get about 7,000. And a new prospective Institute of Medicine study suggests that there are about 7,000 drug-related deaths. So a lot of criticism about this early in terms of being a meta-analysis. Maybe they overestimated, but at least new data supports that they were about right in terms of medication errors. I'll come back to categories, but just so you can see a little bit about describing medical errors. The common ones are due to technical, so these would be in the course of procedures, for example, or even the wrong procedure. I mean, the most egregious example would be the wrong leg being removed at surgery. But think about it, the wrong person having an MRI, right, with contrast, may be a person who could be seriously injured as well. So that would be called a technical error. So I'm an epidemiologist, and I tend to like to look at things not only in terms of numbers, but in terms of rates. So here you see again the 44 to 98,000 fatal errors, but Troy and Brennan and his colleagues who've been studying this for a number of years, including in my state, in Utah and Colorado, By reviewing medical records, professional reviewers, these are not lawyers, now these are physicians that are reviewing medical records, not just cases that have been litigated, but just medical records. As they review the medical records, and I'll define these terms for you, they found that about 3% had in the record evidence of an adverse event. And remember things being overdetermined? Well, I'll describe an adverse event, but an adverse event per se doesn't mean a medical error, but it could mean. So the next category was what they called negligent adverse events. They had an adverse event, but as they looked in the record, for example, easy to understand, it's a patient with a severe reaction to penicillin. Definitely an adverse event, for sure. But if they also found in the record a history of allergy to penicillin, the patient shouldn't have received it, so this is an adverse event that would be called negligent. So again, notice the proportion. So good news, first news would be they didn't find those very often. Just a little less than 1% of the records that they looked at had an adverse event due to error. By the way, if you do a lot of telephone calling, how often do you dial a wrong number? People say about 4%. The human error rate, or if I ask a secretary to transcribe a document, right, that's typed and she's going to type it again, you look at the number of characters, it's about 4% that will be transcribed incorrectly. So here's again good news, that our negligent error rate is a little lower than what you might expect. That must mean people are being careful. So that's a good start. Our rate is lower than what you might anticipate, but when the consequences are so great, right, you don't want to go to the hospital with a chance of a 1% error rate that could affect your health. So there you go. So that's an interesting ratio. It's about 1%. So we know, how frequent those errors are. And again, I just, what are my qualifications for talking to you? I think we all acknowledge making mistakes, but I think for a while I was actually pretty expert in my field in infectious disease. But I have to tell you that I lose my expertise pretty regularly. That is, I've made most of the mistakes I know with aminoglycosides. I made those years ago, and I don't repeat those mistakes. But every time there's a new class of drugs, you can be fairly sure that I will be somewhat behind the curve, and I will have to learn from the mistakes that I've made. By the way, and sadly, that's actually something positive to say about mistakes. There's actually no more effective teacher for anyone, including a physician, than a mistake that we made. The sad part is, right, the consequences of who has to experience the mistake. My child, when he went to school, I guess in the second grade, the teacher had a sign on the board that said, "Mistakes are how we learn." And so he would bring papers home with mistakes that he would, quote, remedy and bring back. And he really did learn from those mistakes. But that's very different than a medical mistake. So what would I like to do today? Well, the D's seem to do it for me. I told you that I would define, and I will, terms like medical error and adverse event. I'll describe a little bit more of the categories and epidemiology, but I'll put my emphasis, and I'll say a word or two about discovery, but real emphasis, I think, on disclosure. And what I'll talk about there is whether or why we should disclose, when is the right time to disclose, and particularly how to do it, which goes all the way back to that idea of unmasking. That is, it's so difficult to do this because of the emotional fears that I've talked about that we actually need a skill set. We need to be reminded that it's also difficult to open the chest of a patient, right? But we learn how to do that by learning the skill and how to do that safely and effectively. And I think there's a skill set to be learned here as well. So here are some mistakes. The common one would be this one. But I think it's helpful if you think of the medical context. These are errors in general. And mistakes would be an error or a fault resulting from defective judgment, deficient knowledge, or carelessness. So if you just transpose that into medical language, you could think about lack of competence, or medical judgment, or negligence, if you like. So I think this concept of a mistake is pretty a good one to guide us. And then the Institute of Medicine, and I may need a little help to change my slide here. Let's see. The Institute of Medicine said error, and you want to read this carefully with me, and you won't see the word outcome in this definition. It's the failure of a planned action to be completed as intended, that would be an error of execution, or the use of a wrong plan to achieve an aim, one of planning. So the first thing to say is that they're helping you distinguish between a bad outcome. And as we'll see, a bad outcome is a reason to ask the question, did an error occur? But the outcome itself is not evidence, right, that an error occurred. It could have occurred. So what you have to back up to do is to say, well, what was our plan? Right? And if, for example, if I wrote a drug order and my handwriting was careless and the dose was misperceived and overread as 100 times, my plan was to give 0.1, and what was given was 1.00. So I had the right plan, but it was a failure of execution, correct? And then the next one is wrong plan. So we're back to my penicillin story. Penicillin is a wonderful drug for pneumococcal pneumonia, and I prescribed it for a patient. But I also saw on the front of the chart the patient was allergic to it. I want you to see here a nice example that an error can occur with no consequences at all. Take my story. Patient with pneumonia, I prescribe penicillin, nurse reads my order and calls me. Was there an error? Well, yes, there was. Was there a bad outcome? No, there wasn't. In aviation, that might be called a near miss. So another thing to realize, and we miss these all the time, the errors we're most aware of are the ones with serious consequences. But they're actually not as frequent as the errors that never have consequences at all. But again, the lesson would be the more we learn about managing those others, which, by the way, are not as emotionally freighted. Which call would I like to get? Your patient is seizing and in anaphylaxis in the ICU because of the penicillin you wrote, or doctor, I noticed that you wrote penicillin and it says here the patient is allergic. I want the near miss, right? And that has just as much value to me as that awful consequence, because I can see, I have a good imagination, I can see what would have happened had the nurse not called me. So I have very powerful emotional learning from that mistake. Second category, an adverse event is an injury and it's predictable. It's caused by medical management rather than the underlying condition, and if it's attributable to something that could have been done differently or not been done, we're going to call it a preventable adverse event. So the penicillin is a perfectly good story. A patient who's never had penicillin before, for whom I prescribed penicillin, and who's the same patient, seizing it in the ICU, has had a very bad adverse event, but to my knowledge, it wasn't a preventable one. See the difference? Okay. Negligent goes one step further, and it's where I fail to meet the standard of care. So my pneumonia example would actually be in two categories. It was obviously preventable. There are other drugs I could have given. And it's negligent because the evidence of allergy was in the record and I missed it or ignored it. So that's the category that I think people think about when they think about litigation. And again, I remind you that even negligent adverse events wind up in litigation a very small portion of the time. So there are many negligent adverse events, we'll call those serious medical errors, that are never litigated. And a bad outcome is huge, right? It's disappointing. It's whatever happened to you that I'm sorry about and that you regret, right? That's, you had surgery for your hip and you can't do ballet, right? You can do everything else. You can win bicycle races. That's a bad outcome from your standpoint. And bad outcomes, if you've investigated and you don't find mistakes or adverse events, they're not that. They're an undesired and unfortunate result for which we can feel sad, but not culpable. By the way, another problem about managing mistakes. When people have unfortunate outcomes, we're very prone to say, I'm sorry. I say that when someone loses a relative in my community. I have nothing to do with that death or loss, but I am sorry. But in this climate about medical mistakes, public perceptions, misperceptions, and lack of trust, when people say they're sorry about a bad outcome, there could be confusion that the I'm sorry is actually acknowledging responsibility. So it's just another level of complexity I mentioned before, and I think it's both intellectual and emotional. So I said I'd do a little bit of description. I'll just give you a minute to think about these. I've defined mistake for you. If that's true, don't these strike you as a little paradoxical? What would be a normal mistake? What would be an unavoidable mistake? Right? If the definition of a mistake, right, is that sufficient knowledge could prevent it, sufficient judgment, et cetera, what would that actually mean? And the same thing about a normal mistake. Well, I've talked to you about the human error rate, right? But now take that back into the medical context. Are we all right with 4% of patients having mistakes? because we say that the normal error rate is 4%. So once again, I think this points out the complexity of what we deal with, because these are very common notions, but they won't work in discourse with doctors and patients. Try that, right? Wrong leg surgery. Well, we've done 4,000 leg surgeries here before, and this is the first time it's happened. That's actually better than average. I don't think so, right? I think there's cold comfort in being told that, you've had a mistake and that the error rate was normal. Well, think back to the graveyard scene. This is Marianne Paget again, reminding us that our mistakes don't appear as that. They're mixed in with things that we see in our work environment: wrong results, injuries, and even unresolved illness. So I'll just tell you from an infectious disease perspective, I took care of a gentleman probably in his 50s, done a lot of international travel, long-term smoker, had chronic lung disease, pneumonia, and a pericardial effusion. We evaluated his pneumonia. It was due to a bacteria, Haemophilus. We were unsuccessful in tapping his pericardial effusion, but we know that that organism can produce pericardial effusion, so we treated him for Haemophilus influenza. He did reasonably well, but not great, and left the ICU, left the hospital, etc. I was at my infectious disease case conference 6 months later, and a patient whose story seemed somewhat familiar to me was being presented. It's a story about a patient who had TB pericarditis. And as the story unfolded, it was clear that he was in the hospital 6 months earlier. And my colleagues did, as they often do, and they said, well, who took care of him? So my colleague in my division said, well, that would be Dr. Jacobson, who didn't get a specimen for TB and treated him for Haemophilus, pericardial effusion. So that was a disturbing experience with learning about a medical mistake. And it's actually a very powerful one. I think that's actually a mistake. There's a teaching point here that I share with you as mentors of residents and students. The time to tell people about their mistakes is when you know it, and the place is not in front of 40 of their other colleagues. Right? There are better ways of doing that kind of disclosure. But it really was the case that but for that conference, I would never have known that I made mistakes. It's a very powerful example to me and very representative of the way that I have relationships with patients. I see them in the hospital, and then I may not see them again at all. From that IOM report, you saw these categories: technical, diagnosis, etc. But I think some of you are familiar with the idea of omission and commission. And sometimes those are very charged concepts. But I would just say, if you're a patient on the other end of a medical mistake, that's really not the critical issue, right? Same thing, miscommunication, no communication. And a sense that we're all coming to is that even when we think of mistakes as individual, and doctors, I think, are very prone to feeling responsible for mistakes or mistakes that happen to their patients, we learn increasingly that those are very complicated, that many, many, many elements need to go into a mistake happening. Remember my story about the near miss. Lucky for me, most nurses know to call me. I live in an environment where they're comfortable with that. But imagine me practicing in another hospital where the nurses have been terrorized and I'm a new member of the staff. And so I write a drug for a patient who's allergic to it, and the nurses have been conditioned not to call and get yelled at when they make those suggestions, right? So the patient gets it and gets sick. It feels like my mistake, but it really is complex, right? There were other people in the chain. And so this is just to make that lack of clarity really evident. That is, bad outcomes and adverse events do not always equal mistakes. And of course, as I've mentioned in the near-miss example, mistakes don't always lead to bad outcomes or adverse events. So with that level of complexity, how do we ever figure out what's a mistake and how do we recognize them? This is not an infrequent way that we handle things. This is lack of knowledge, right? This is a patient who will say unexpectedly expired, and one colleague is saying to another, well, shows you how much I know. Well, that's pretty tragic, right? But is it clear that there is a mistake here? I mean, it sounds kind of embarrassing, but does anybody know why this patient died? Is this a bad outcome? Is this an adverse event? Or is this a preventable adverse event? It's not apparent right on the surface. So how could we do better? Well, I'm really fortunate that I work at a system where there is a little bit better oversight for me, and it's non-personal. It's the computer. So just as I mentioned the examples of where if you're a bad speller, your computer spots your mistakes and even offers you a solution, I work with computers that will both remind me and correct me. I'll write a good example that I mentioned earlier, an aminoglycoside dose for a patient I'm seeing in consultation, and I'll write a standard dose. And the computer will say, well, there's evidence here that this patient is in renal failure. You probably don't want to give that much, and here's a suggested dose that we've calculated for your patient. So there are a couple things going on there that really help me. So allergy, my other example, in the record and software written that says, I don't need the nurse to call me now. And by the way, the computer doesn't feel threatened by me, right? It actually, if you read computer alerts, I mean, they can be pretty aggressive. You know, they can even flash. And that's what ours does with that kind of a serious allergy. And it won't accept the order. So, I mean, there are just a lot of safety steps built in there. But the rest are really your choice and my choice. The personal one is for me to just review what I've written, right? It's to take a second look, to look at my orders after I've written them and to just do that much. Because as you know, that's what you did when you took math tests as a kid, right? You looked at them one more time, and the mistake you made the first time, you noticed when you went back. So we can review our own stuff. I can ask my colleagues to do that. And by partners, I don't mean my medical partner in a practice. I mean the nurses, the pharmacists, and I would actually put my patient in the category of partner as well, which is, does this look right to you? And each of those partners has a different set of expertise and skills to evaluate what I've done. Quickly, I'm going to talk about 3 perspectives on disclosure, and they're the one from our profession, the way patients feel about it. By profession, I mean our professional societies. Next would be patients, and then ourselves as physicians. So these are not complicated. If you look at professional codes about what we should do with mistakes, you will read that we shouldn't make them, right, or make as few as possible. We should be competent, we should be retrained, we should be continually educated. But they do acknowledge that we will still make mistakes. So the AMA says that if we do, we're ethically required to tell our patients of what they need to ensure they understand of what has occurred, and they go on to say it's only through full disclosure can a patient make informed decisions regarding medical care. You can actually read even in that what their ethical basis would be. So a lot about informed consent, maybe truth-telling. We're obliged to let patients know what they need to know. That's a good one to kind of keep in mind because that's a framing idea, right? How much do I need, would I need to tell you about a near miss? We'll go back to my patient with the allergy to penicillin where the nurse called me. Do you need to know that I came this close to sending you to the ICU? Well, from this statement, you know, you've got facts necessary of understanding what has occurred. Well, do they really need to know that? Some of us, I think, would say, what a lesson. Maybe I should actually let my patients know. Change the example slightly. It wasn't penicillin, it was ampicillin. But the nurse understood they're very closely related, but the patient might not have. So that might actually be an opportunity to say to the patient, here's something for you to know. In the future, when you're in the hospital, if you get other drugs that end with ILLIN, even if they're not penicillin, it might be really good for you to ask people to take another look at that before it happens. So tell people what they need to know. The ACP manual, pretty similar. Physicians should disclose to patients information about, I won't read every word, errors that are made during the care if it's material to the patient's well-being. Well, that's actually a little different, right? Would you like to know what the risks are to you when you're in a hospital? Would you have more or less confidence if somebody told you, A, about what the risks are, and if I told you, for example, about the computers that I have that will help me minimize those risks in the future? So a little broader. But the last sentence, I think, is very helpful. The errors don't necessarily constitute improper, negligent, or unethical behavior, but failure, and the failure here is failure to disclose. But failure to disclose may. And I'll focus on the unethical and improper. If you go outside of medicine, this is what other people think about what to do after a mistake is made. And so I think that Confucius had lots of good medical advice for us. If you've committed a mistake and don't correct it, that's actually another mistake. And I think you could actually argue, as Cicero said, that if you're ashamed of mistakes, and what a shame or shaming would do would definitely block disclosure. Those are the two things. Shame doesn't stop you from correcting the mistake, but it does inhibit you from disclosing it. So he writes, if you're ashamed of mistakes, you may turn them into crimes. So he's actually saying, and I think that's a nice acknowledgement, we've talked about the human error rate. Even with the IOM and safety, we will still make mistakes. What's in our control? We can try to minimize mistakes, but we'll never zero them down. But the choice about disclosing is actually our choice. That is, that's something that you actually completely control. You can say 100% of the time, I will disclose, or 0, or any number in between. I mentioned that I would share a patient perspective, and here it is. And again, it's not complicated. So in terms of the colored bars, they ranged from the lighter color, a minor mistake, to the darkest, which is a severe mistake. And here's pretty much what patients say. In terms of, do you want to know from the doctor that a mistake was made? I mean, is that close enough to 100% for you? Okay, and it doesn't matter whether it's mild, moderate, or severe. So if you think about the well-being of the patient and the ACP, patients are telling you they want to know if a mistake is made. Interesting to know what their reaction is. In terms of wanting a referral, if it's a minor or even a moderate mistake, less than half of them want to go somewhere else. They're willing to stay with you and have you continue their treatment. As you go to financial compensation, I think it's what you'd expect. If they're minor or moderate, most people are not even looking for that. And I think, interestingly enough, even with a severe mistake, it's only about 60% that say that they would wish some kind of financial compensation. And this is also pretty illuminating. And what I'd like to call your attention to is in each category, look at the comparison between what happens in the space between informed and not informed. So, for example, and let's just go to the one that I think that people worry most about, which is lawsuits. So on the last line, or last set of 3, it says I'd file a lawsuit, and they're categorized by minor, moderate, and severe. And as you read across, for minor mistakes, if people are informed, it's about 4% that would litigate, moderate 20, and 76 it was severe. But I think the interesting news is to read the same thing on the next line, which is what people would do if they were not informed. And the assumption here is not informed, but later discovered. You have to assume that. So for minor mistakes, not a lot of difference, 4% and 1. For moderate mistakes, 12% up to 20. And even with a severe mistake, more people would sue for the same problem if they were not informed than if they were informed. So you can imagine how some calculating physicians would think about this, right? Their metric would be mild, moderate, or severe. Do they know or don't know? And then the next question would be, how likely would they be to find out? So I'll come back to that in a little bit. Now finally, this really, although the slides have patients and physicians, what I will tell you is this is the way physicians think about patients. So this is heavily oriented to a physician's perspective. So physicians fear, or let me start by saying they have many ideas about disclosure, and I will go through them talking about harmful, that not disclosing can also be harmful, and then some ideas about how they might be helpful. But these are from the standpoint of docs. So docs think and are correct in believing that patients who hear about mistakes that have been made could be angry, upset, or scared. And it could be that that disclosure could make them overly fearful. And for the docs themselves, they're correct that they could be sued for malpractice and could actually lose the trust or maybe even the custom of their patients. But the flip side of this is that not disclosing can also be harmful. Remember, it's like mistakes. These are very complicated. So again, from a physician's perspective, they would know that a patient, for example, think about my near miss, right? If the patient doesn't understand that analogs to penicillin can be just as dangerous as penicillin, they don't hear that, then they're unlikely to be really an advocate in their own behalf in the future. So they may not take corrective action, or they may actually take the opposite of corrective action. They may have had an adverse reaction to a drug, but they're experiencing pain, for example, and they think that means they need more surgery. It's all very confused, right? So they're going down the wrong road because they weren't told what happened. And of course, they may incur additional personal expenses or losses. A physician that's trying to conceal a mistake may be inhibited from taking corrective action because taking the action, picture, you need to go back to the OR, right, reveals that there is a problem that needs to be addressed. And of course, later, if that undisclosed mistake is discovered, you can be pretty sure that that will generate anger. And that, of course, could further lead to suit, or the physician himself or herself may be experiencing guilt not only over the mistake now, right, but remember the quotes about the crime of not disclosing. So it's a doubly challenging problem for the doc not disclosing. And then here are some of the helpful things, and they're just the converse of what you've seen, but I'm going to emphasize ones that are really worth talking about. If there's any way in which a physician who's feeling terrible about a mistake can deal with that feeling terrible, it's actually only through disclosure. That is, it's the person that you've harmed that has the exclusive ability to forgive or absolve. Now, it doesn't always happen, but there is no other way. So that's actually almost a unique aspect of disclosure for physicians. And another way that they can be helpful is, you know, that one about when first we practiced what a tangled web we weave? Well, so if you disclose, you don't need to do any kind of prevaricating or deceiving or steps to kind of keep up the masquerade. And another paradoxical thing is that acknowledging a mistake could actually result in more trust. I mean, let's grant that it could resolve in lost trust, but sharing something that people know is so difficult can actually be trust building. And again, just like absolution, I think someone who has had dialogue with a patient who has been harmed may feel less remorse. Well, here are some numbers for you. Now we're going to talk about what physicians say or do as opposed to these possible ideas. So now we're talking about disclosure. So when you query American and Canadian physicians about whether serious errors should be disclosed, remember patients, 100%, it's almost symmetrical. It's almost all the docs who say, well, of course. But then you go a little deeper. Remember the ones about discovered and undiscovered? So the investigators here are separating that. So now they're saying, well, if it's a serious error and it's obvious, would you disclose it? Now we're down to 81%. But if you ask those, how would you tell patients what happened? 42% would actually say that an error had been made. Others will use the language of bad result. Something happened. My favorite use of the passive voice. Right? Something happened while you were in surgery, and we need to go back. So they're calling that disclosure. And in many ways, that is. I mean, something happened. That's a true statement. But it's not disclosure that an error happened. So you see we're down to 42%. For an inapparent error, one that's unlikely to be discovered, now we're down to 50% for a start. And it's only a fraction of those that would use the word error in their disclosure. Apology, and I'll come back to that in a little bit, is pretty infrequent, and it's only about a third that would explicitly apologize. And then these are career physicians. These are physicians, you know, in their 40s, 50s, and 60s. Can you imagine how many serious errors we've all made over that lifetime? So if you ask them now, we're not doing the survey, we're just saying about your experience, how many of you had disclosed a serious error to a patient? It's only 58%. So in terms of practice, it looks like it's the case that disclosure is much less frequent than we would imagine. And if you want to imagine the conversation, it probably was disclosure that something happened, not about a mistake. So we're not doing what our professional societies pretty much tell us we should do. This is the way we disclose. So his life was hanging by a thread, and then somebody fed him that bean burrito. Can you read this? Listen up, my fine people. I'll sing you a song about a brave neurosurgeon who done something wrong. That might actually be the Louisville song here. But this kind of, and it just shows you how uncomfortable we are, right, when we're talking. So we talk around, or if you like, we sing a song around what happened. And I love this one. Okay, so that's the good spin, right? Lucky you. I mean, where else might you have been today and had this great good fortune? Okay, so I mentioned earlier I'm especially concerned about residents, and please remember my first slide about see no evil, hear no evil. So residents do talk of mistakes, about mistakes, but mostly to each other, often to their partner, to their spouse in this case, about half of the time to those of us who supervise them, but only about a quarter of the time to the people who've been affected, right? And I want to say that this is a teaching opportunity, right? Because first of all, when the residents have made a mistake, it's actually our responsibility as well. So I think we need to be there, and we need to think about that as a learning opportunity in the same way we think of doing lumbar punctures. That is, we need to tell this patient about a mistake. You need to come with me. Let's do that. if we don't disclose fully and to the family, and this is our preferred approach in medicine, by conceding errors to our friends or maybe even our peers who don't criticize us, Friedson wrote, one gains the cathartic benefit of confession while avoiding the price of penance. And I think there's more to it here, because it's not only avoiding the price of penance, it's avoiding the opportunity of absolution, right? Because our friends were not the injured parties, and so all of their comments about I've been there also, or they're there, anybody makes mistakes, doesn't really address the issues that we have internally. I think I'll just do this very briefly and tell you that no matter how you slice it, whether you're a deontologist or utilitarian, disclosing mistakes pretty much comes out as the right thing to do. And the simplest way to get there, I think, is the rule we're all familiar with, which is do unto others what you want them to do to you. But for physicians, actually, I don't know if anybody else likes this, I call that the platinum rule, which is I wouldn't expect patients to feel obliged to tell me, they're late for the appointment and they're going to apologize and all. They don't have to do that. But I have to tell them that I've hurt them because I know it and I know hopefully what can be done to help them. And that general rule about putting their interest above our own, I think, is good guidance. So really, pretty much no matter how you slice it, I think we need to do it. We're committed to minimizing harm. This is the way to do that. I've shared with you that our professional societies pretty much demand it of us. I hope I've shown you that the public expects it. Any way you analyze it, it's the right thing to do. And this last point I really won't stand on, but I'll just say that it's a possibility that in a given situation that actually might work favorably. That is, instead of it being your fear of litigation that drives you, it might actually be your wish to avoid it that could move you that way. And as I was saying to David, your neighbors in Lexington at the VA actually have some interesting work about actually letting people know about mistakes they wouldn't have otherwise known about, which would be that one about inapparent or undisclosed. And their record overall is that they're not paying more in settlements than similarly situated VAs are in litigation. So maybe, and I'll just leave it at that, in some situations. So what's this idea about putting interests above ourselves? So are we credible as a group when we say, we have your best interests in mind? And I think to the degree that we're honest and we disclose, we're credible, but to the degree that we deceive and conceal, I think that makes a mockery of that claim. David Jordan said, and addressed really the hard place here. So this is not a mystery about what the right thing to do is. People say to me, is this an ethical dilemma? Well, no, it's not a dilemma. It's not two right things competing with each other. We all know what we should do, but it's very difficult. And I think it does take both courage to do it, and it's virtuous to do this kind of disclosure. So let me wrap up with a couple of skill items. So when to do it? Well, remember what we said about bad outcomes being overdetermined? Well, it's pretty wrong to apologize for a mistake that's not a mistake. And that's actually a residency issue. Residents, when they see a bad outcome, are extremely guilt-ridden. And their first assumption is that their patient died because of something they did or didn't do, and they're just human beings. If you talk to people who've had a loss, they will all tell you, if I had been there, right, I could have changed this. So residents feel that really keenly. So if someone dies while they're at home or on a break, it's like their fault. So that's not something to go back and apologize for. Your father wouldn't have died if I had not been drinking coffee. So we need to do ascertainment, and sometimes that means getting expert opinion. It's also a good idea before you approach disclosure to think about what you can do to fix something, right? That would be a good thing because someone is likely to ask you that. Thanks for telling me, but now what are we going to do? Too early if you don't know the answer to that question. So you want to develop quite a comprehensive plan, one for remedy, maybe some other kind of assistance that the patient would need. You actually want a plan where you share that error with others so that that initiates a root cause analysis, and even a plan that would change something that could prevent that mistake in the future. And you certainly don't want to do it while your patient is still recovering from anesthesia, right? I mean, I told you. Well, I don't remember, but I told you. Not useful. So you want the patient ready, and obviously you might want support people there as well. Well, don't do it before, but you shouldn't wait too long either. So as soon as you know there's a mistake, and you have investigated that, and this is not an adverse event, it's one that's a preventable adverse event, it's time to start thinking about disclosure. You want to have your plan ready, and of course the family needs to be ready. But it's still hard for some of us. So this doc says, there's no easy way I can tell you this, so I'm sending you to someone who can. Okay. Just so you know, when patients are queried about who they want to hear about mistakes from, their first choice is a doc, but a close second is another medical person. So a nurse, if the nurse has all the facts and the plan, or maybe the risk manager, is okay. What the patients want to know is what happened and what are you going to do. So if you can't do it, find somebody who can, but I'm going to leave you knowing how to do it. So you ought to have a conversation if you know you've made a mistake with the risk manager, because that could be a part of the remedy. They may be able to tell you that we're going to write off the hospital bill, or we're going to commit to the cost of fixing this. So the risk manager is a good consult. Get yourself ready for the strong emotions that are going to come, which could include anger, rage, tears, frustration, shock. I mean, be ready. Don't wait until patients ask. Good thing for you to remember here today, if you remember nothing else, because things are overdetermined. When patients have bad outcomes, they often think a mistake is made. Right? We all think that. So maybe it's not a bad idea to have these conversations, even when there's not a mistake that's made, so that you can be one step ahead of the curve, which is to say something. And I'll tell you a strategy, but you can say, I regret what's happened to you. You might imagine. Or you might try what psychiatrists would say, which is, what do you think happened? Right? And if they say, I feel a mistake is made, you say, that's understandable. Let's talk about what really happened here. Turns out you have an allergy. We'll chart that for the future. We didn't know that. La-di-da. So remember that patients are often thinking about this ahead of us. Very important is to acknowledge and clearly state that an error has occurred, and explain, if you can, why it occurred, which might be some of those system things. Be specific. Talk about what's going to happen to the patient. Accept responsibility, and don't bore the patient with telling them about all the people who should have done it differently. Right? They're the receiver of the mistake, and it doesn't matter to them that you're mad at the nurse or something else. Take responsibility. I actually think that it is appropriate to apologize, and if we have time, I'll answer a question about the I wish strategy. And I think you want to present them this plan to rectify the harm and what you're going to do in the hospital to prevent recurrence. Other things you can do are offer to get second opinions, talk with their support people, even an attorney, document the discussion for yourself, and make yourself available. And I'm going to end with just a few key points about apology. And these are my reasons. I actually see apologies as a medical tool. So if you'll forgive me, I use the language of medicine here the way you would for a drug. So I've called these the medical indications. The author here, Lazare, talked about them as healing aspects of apology. But hey, look at that. So patients may feel that the fact that you've shared this with them is actually demonstrating to them how much you respect them, the opposite of disrespect. Again, that you're explaining things to them and telling them what you're going to do and that you're making changes makes them feel cared for. They may have felt powerless. I mean, as people do in the hospital, they were sick, now they're sicker, but you're sharing something with them and they're a part of their own recovery. Sadly, this is a little bit like Schadenfreude, but they're angry that a mistake is made, and if they can see that you're actually really, really upset about it yourself and you're suffering, that may actually make them feel better. It's actually what we want to see in people who have hurt us. I mean, that's a measure of apology, is how badly they feel. It is a validation of them as individuals, and if you're going to talk about how this happened, you're not there to tell them what they did. So the patient in the recovery room who fell out of bed, right? And you said, well, you shouldn't have tried to go to the bathroom, right? That's not the point. There's supposed to be rails up on the bed when people are in the recovery room, right? So this is not the point to tell them it's their point. It may show them that you share values. There's a chance for them to be in dialogue with you, hear how you feel, maybe work on a solution. Part of the apology may be reparation and maybe a promise for what you're going to make available to them in the future. Now, what does an apology need, and what are the active ingredients? And it's like a drug, right? Or maybe a combination chemotherapy for HIV. If any one of these is missing, you can be sure that that apology may fail. So here they are. The first one is specific. Not something happened in the operating room. Okay, it's an error was made. It's an explanation to the extent that you know it, and you can say that you don't know it all and you're working on it, but you're trying to understand why that happened, and the patient wants to know that. And they want to see these expressions of how this is affecting you emotionally. The only word I think that requires any explanation there is forbearance, and that's your commitment not to make the same mistake again. Right? The rest of it is pretty natural. You're going to have those feelings. And reparation is what you're going to do to make it right. Well, I think we've covered the ground. I said to you it's a lot of D's. I hope we've defined medical mistakes, described them, talked a little bit about how hard it is to discover them and how we might do that, and emphasized, as I said, both the difficulty and some skills that might be involved in disclosure. And I think that this is really the summary for what I'd want you to remember, that the mistakes will continue to happen, but what can change is our response to error, and that matters greatly. So there are some references for you, and this is an apology some of you might remember that didn't have all those elements. Okay, well, let me thank you all, and I'm happy to stay if you have some questions, but I'm watching the time, and I know that we're right at the edge. But thank you.